Good afternoon. My name is Liz Keating from Dementia Australia's Centre for Dementia Learning, and your host for today's webinar. A very warm welcome to you all for Dementia and Palliative Care Compassionate Pathways. Just to let you know, this webinar is being recorded. Well, we have a wonderful panel lined up for you today, and I'll introduce them to you shortly. We'll touch on our carefully considered objectives for the hour together. I'm very excited to share with you today some excellent news in relation to our topic about our award-winning app Ask Annie, but more on that later. And I'll also touch on how you can actively engage with the webinar discussions in a moment. But first, I would like to acknowledge the traditional owners on the virtual lands on which we are meeting today, and pay my respect to elders past, present, and to our shared futures. Now, whether you've chosen to join us today to build on your organisation's capabilities, identify areas of opportunity to expand your own skill sets around death and dying, and all things related, or perhaps you may like to check in and reaffirm that you are on track and you and your organisation are in a state of readiness for the release of the strengthened standards in a few short weeks. Whatever the reason, we hope you find the hour ahead to be one of value. So just a little housekeeping. You may notice your microphones have been muted. However, if you are joining us from a laptop or desktop computer and you have any burning questions throughout the hour, we ask you to add those to the Q&A box, which is located on the top left-hand side of your screen. And you can like the questions you would like to see answered by hitting the thumbs up emoji. And time allowing, a couple of the most popular questions, which will be identified by our wonderful moderators working in the background. They will be responding also to those online questions, but we'll turn to them later on in the hour for those couple of questions. We will also be identifying the top 5 most popular unanswered questions, and they will be published along with the link to the recording of this webinar, which will be released in due time. So our objectives for today, which have been carefully selected, they're aligned with the upcoming standards, in particular relation to our topic today, and they are to examine the intersection of dementia and palliative care, discuss the implications of the strengthened standards for palliative care and residential aged care. We'll be looking to share practical tips for initiating those early conversations about palliative care and dementia, and reflect on key considerations during the end stages of dementia. I'll also be asking the panel questions for them to share their expert perspectives, and it's my pleasure to also be introducing the new Ask Annie module, a palliative approach to dementia care. And now to introduce our wonderful panel. Psychiatrist Dr. Arthur Kokinius, who has worked in the fields of public mental health and in private psychiatric practice for over 25 years. He graduated in medicine from the University of Melbourne in 1992, completed his fellowship of the Royal Australian and New Zealand College of Psychiatrists in 2000, and the following year completed a Master of Medicine majoring in psychiatry. With a strong interest in chronic pain and cognitive degenerative conditions, Arthur's passion in promotion of quality education within the profession and to the wider community, especially to those with limited English skills. A large number of Arthur's patients are senior Greek-speaking migrants and Australian-born people of Greek heritage. As board member and secretary of the Hellenic Medical Society of Australia and currently the head of service psychiatrist at the Community Mental Health Clinic of the Royal Melbourne Hospital, he has spoken at a number of public lectures and seminars on mental health disorders, including psychosis, mood disorders, and dementia. We warmly welcome Dr. Arthur Kokinius. From Frondita Aged Care, Louisa Storer. She has worked in aged care for more than 20 years, fulfilling a number of roles, including a personal care worker, a registered nurse, clinical care coordinator, and today acting deputy manager of Frondita Residential Aged Care. Louisa has a passion for providing person-centred, culturally relevant care and palliative care, and also in supporting families and loved ones through those difficult times. Louisa has been involved with continuous improvement projects to support and educate RNs and PCWs in aged care to feel more confident in providing excellent palliative care. Welcome, Louisa. And from Dementia Australia's Nightingale Project, Geeta Khadkar, who has been with the Nightingale program for 2.5 years now. Prior to that, she has worked in residential aged care, holding management positions, and has worked with ANAC, the new aged care funding. The Nightingale program is a palliative care model for advanced dementia. It's available in South Australia and select New South Wales locations. It provides free support through specialist nurses and an occupational therapist in South Australia, and offers care strategies for individuals, families and care providers. And I suppose key strategies or key services for the Nightingale program include promoting independence, quality of life and decision-making while avoiding hospitalisations. The program also provides clinical advice on comorbidities, pain management and palliation. It's funded by South Australia by the Rosemary Foundation for Memory Support and Country South Australia Public Health Network. Welcome to you, Geeta. And I'd like to open the discussion with a question for you, Geeta, if I may. Let's start by understanding the connection between dementia and palliative care. Geeta, often people do not think about dementia being a life-limiting diagnosis. Can you please share with us, how does palliative care apply to dementia?
You're correct, Liz, that dementia is not looked at as a palliative, especially during the early stages, because there is not much knowledge around the community about dementia and how it is a palliative care. So dementia, when we get the diagnosis of dementia, palliation starts from day one because it is life-limiting illness, because dementia is an umbrella term used for multiple type of dementia like Alzheimer's, vascular, Lewy body and frontotemporal, which has got their own prognosis, such as Alzheimer's has 6.7 years for males to 7 years for female. So when we get the diagnosis of dementia after the test, the GP can probably guide the patient living with dementia and the family members, explaining how dementia can be life-limiting. We're not going to talk about death and dying just yet, but palliation that can start by looking at the advanced care directives and providing compassionate and holistic care to the person living with dementia, so that when the cognition declines in future, there are some strategies and some goals to be managed.
Doing some wonderful work there, Geeta. Thank you. Thank you. So now I'd like to turn to Louisa. Louisa, could you tell us a little about how you approach the palliative needs of your residents or consumers, especially in the environment that you work within?
Thanks, Liz. So we, a lot of our residents have a diagnosis of dementia when they're admitted from either to residential aged care. They have dementia, and they also, which is a life-limiting diagnosis, as Geeta's just emphasised, but they also have other medical conditions that are chronic and acute and are likely to affect their life and quality of life. We have some cultural considerations too. So our residents are primarily nearly 100% of Greek backgrounds, Greek-speaking residents. Here, death and dying, or talking about death and dying, is a little bit of a taboo in the culture. So most of our residents come in without an advanced care directive. It's not something they've talked about before. So it's a new conversation that we have to have with them. And as Geeta mentioned, sometimes we approach it that we're not talking about, or there's a misconception or an idea that palliative care is all about dying and death. But we try to emphasise and making sure that the person's preferences So we're looking at the strengthened standards coming in early July, and there's just such a huge focus on the resident or the preferences and respecting their preferences and their wishes and dignity at every stage. So we try and have conversations with the resident or their representatives about what they would want for themselves, what would make them feel happy and fulfilled as they come to the end of their life. So we have some really great conversations with people, and we're able to put plans into place to make sure that their wishes are respected. So look, we're, in residential aged care, we've always provided palliative care, and there's just more of a focus now in the aged care, in the strengthened standards, of making sure that that's consistent and planned for each resident.
Right.
So we sorry.
You're right. I can imagine it would be particularly challenging, Louisa, in an environment of, increasing resident complexity, and of course working within, as we all know, a resource-constrained environment.
Yeah, that's right. Residents enter aged care, residential aged care. There's a lot of support and funding, which is amazing, for people to stay at home for longer. And that is a lot of people's preference is to stay at home for as long as possible with supports. But then by the time they enter residential aged care, they have very complex and advanced needs, and often there's a crisis at home, or either a health crisis or a crisis with support. So people come in and they're really quite desperate, and then very glad to be here. Often there is yes, resource constraints. I think we also find that there are a lot of supports for us too. I've been working in aged care for more than 20 years, and I really think that now we have more supports. We're able to link in with more external supports, which are really, really helpful for us. There's community palliative care services, and the community palliative care that we're in our catchment, they have a dedicated aged care team now, which is just incredible. So in the past, they were maybe only able to support us if someone had really hard to manage palliative care end of life symptoms, but now we're able to refer residents very early in their deterioration or their palliative care journey, and community palliative care are a wonderful support for us and for the residents and their families. Even since COVID, the virtual Victorian Virtual Emergency Department, so VVED, if someone has a sudden decline, or there's an acute health event, maybe in the past, that would have necessitated a transfer to hospital if it was something we weren't able to manage immediately. But now if it's the resident and their family's preference, we can link into VVED, and the doctors there just have really wonderful detailed conversations with their family, and we're able to support them here if that's their wish. At Frondetha, and I know a lot of other aged care providers have impressed are able to have end of life medications on impressed. So that also facilitates people being able to stay here and have their end of life palliative care here.
Right.
So yes, there are resource constraints, but there's also a lot of services that are available and links that can help us.
Wonderful. Thanks so much, Louisa. We're having a few little difficulties with the internet there, but thank you so much. I'd like to extend my next question to each of you on the panel in order to gain your own unique perspective. Starting conversations about end-of-life care can be challenging, we know. How do we initiate these discussions early in the dementia journey, and how do we ensure that these discussions are person-centred? Louisa, can we go to you first with that one, just while we've got you there?
I think it's on our admission schedule on our first day. So we like to know if the person has an advanced care directive. In our particular cultural group, it's very rare that someone has an advanced care directive, or even has even discussed or thought about resuscitation, things like that. So it's difficult to discuss on the first day sometimes, but we plan it into subsequent care planning discussions. Sometimes if families, residents, or their families representatives aren't comfortable with direct questions about end of life, we can talk about maybe other family members. If someone else had died, how was that? And was that what, if dad has died, how was that? And is that how your mum would like things to be for herself? Whether the person becomes distressed or disoriented in hospital, how can we prevent that from happening? What's important? What makes life good for this person can lead into what would make palliative care or death be as good as possible for this person.
And can you just touch briefly on training staff in person-centred communication?
Yeah, so we have developed this new app with Dementia Australia, Ask Annie, which helps our care workers to think about some stages of palliative care and communicating with residents and their families. They're very sensitive questions, and people are. We bring our own feelings about death and dying and palliative care to it as well as staff. So we provide some training and support to staff with that. We've also linked in with our community palliative care team, and we have rounds meetings every month or 2 months where we discuss residents who are at risk of dying or who don't have palliative care plans, but also we practice, how we might bring up, practice some of these conversations and role model conversations that we might have with residents and their families, so that gives us some confidence and a feeling of being prepared when we go into them sometimes.
Great, thanks, Louisa. Role modelling is a powerful tool. Geeta, what are your thoughts with regards to facilitating those person-centred conversations?
Thank you, Liz. As Louise said, it is not easy to start that conversation because someone has got the diagnosis just now, and we're talking about advanced care directive and palliation. So giving them some time, when they first get the diagnosis, they're still with us, and they can make decisions. So letting them know that there are ways to live well with dementia, and what to look for, like getting advanced care directive sorted if that's what they want for their wishes, or if they don't want, then in future, if they want their family to take that decision, which is absolutely fine. So respecting that would be kind of person-centered for that particular family, and also being transparent about the disease and its prognosis and where it's going to lead to, will give them a kind of a guidance on how well and how planned they can be for the future, and validating the emotions rather than commenting, like, understanding their understanding of dementia so that you can add your input is also kind of helpful. And it is important to understand individuals' preferences, like Louise mentioned earlier, respecting the culture and wishes, because we all live in multicultural societies. So respecting that and guiding and creating a care plan, considering the cultural aspect, will take us on the long run, because we don't know what that person is living with. So just getting how they've lived, what their choices are, and what makes them happy. Because as dementia progresses, their cognition is going to decline. They're not going to be able to answer yes or no or understand what we're doing. So getting those kind of information is really helpful towards the end stage of palliation.
Wonderful. Thanks so much, Geeta. And now turning to Dr. Arthur, your thoughts on those conversations and aligning with the person's and the family's preferences.
Yeah. Yeah, thank you for that. I agree, with Louisa and Geeta with all those important points. I mean, my involvement with people who have dementia is more in the earlier stages, and sometimes in the later stages as well, but more from a psychiatrist's point of view, and seeing people who often have psychiatric issues as well, but not always. A very important part of my early assessment of anyone is to talk about advanced care directives and also talk about powers of attorney in a very general way, which I think people do accept regardless of their own personal or cultural issues. And I think the earlier these things are spoken about and clarified, the easier it is as time progresses, for sure. The other important point I would make is, with my more psychiatric or medical hat on, it's important to really be aware of the cognitive abilities of the person when discussing anything with them. So obviously, whether they're competent enough to understand what's being explained at the point where they are with their dementing illness, and some people will be able to grasp the concepts of their disease even at very late stages of their disease, and others obviously won't, even at much earlier stages. It's incredibly important to try and elicit what the understanding of the person is from not just from a simply cultural point of view, but also from a spiritual point of view, but also from the point of view of how the family works and what the family dynamics are all about, and who potentially leads decision making in a family. And I know all those things can be very difficult to do, but when you get to know the person and the family, that's obviously one thing to be working out and be very very aware of, because it may well be that, as I've seen very often in my private practice, there are big disagreements in families, as I'm sure everyone has seen in the past, and it's really terrible sometimes to see when people are not on the same page for whatever reason, and that can be a very tricky path to navigate, and very very traumatic for everyone involved.
Thank you, Dr. Arthur. I can imagine, that the biggest struggle with this whole topic today is those challenging conversations and how to navigate them carefully and sensitively with the person where possible, and also the family members. Thank you. Louisa, looking now to some of the common symptoms experienced by people in later stages of dementia, what do you feel is the most important thing aged care workers can do to improve the lives of the residents and their families experiencing dementia and palliative care?
Thanks, Liz. I think we just need to recognise when there's changes. So someone, as they live in residential aged care for some time, inevitably there is a decline, and sometimes people improve at different stages, but one of the most important things is just recognising when there is a change or a decline, and communicating that to the doctors and to the family, and working together to see what that means for the resident. And so one common thing is obviously changes in appetite, in intake, in swallowing, chewing, and nutrition. So we have nutritional risk or malnutrition risk screening tools that we do, but you know, our care workers and lifestyle staff know our residents so well. They know the residents so well because they're with them every day, and they notice very small changes. It's taking someone a little bit longer to eat. They're having trouble chewing. They prefer desserts more than the main meal, which they used to eat well. And so when we can identify those things early, we can put in place interventions. If it's to do with oral intake, then nutritional interventions, or in line with the person's the resident's preferences, and they're in consultation with their family. Look at risk. If someone is having trouble swallowing, but there might be a risk, but do they want to keep on eating foods that are enjoyable for them and improve their quality of life? Other changes in a person's mobility, changes in their functional capacity every day. If we can recognise those things early, we can see what's going on in the person and put into place interventions or a plan to make sure that they're comfortable and still able to enjoy things that they want to enjoy, and communicating those things to the family. So sometimes we talk about people at risk of dying in aged care. Would we be surprised if this person had died within 6 months? And sometimes we wouldn't be, but are their family aware that they're at that stage? So we try and, or we communicating that to families, to not to alarm them or to be always talking about dying, but to just remind families gently that dementia is a life-limiting illness, and that their person might be declining. Pain too can be. We know that pain is often underreported in people with dementia who aren't able to express their pain verbally, and we've always used the app. We've recently started using Pain Check app, which has really helped us to identify pain in people with dementia who are not able to express it. And so we're able to identify with more accuracy now, I believe, people who are experiencing pain that maybe previously we just attributed to agitation or dementia. So being able to identify and manage someone's pain improves quality of life and ensures that they're more comfortable. So there's so much that we can do, but I think that identifying changes and communicating those changes to the right people is one of the most important
Great, thanks, Louisa.
things that we can do.
If I may ask, it might support us with the internet connection. Are you happy to turn your camera off just as we continue? That might better support the internet connection there. I'd just like to ask you briefly about the importance of teamwork and communication on the topic, and also Dr. Arthur touched on this as well, the importance of recognising when a person's entering the end of their life. Louisa.
Thanks, Liz. Yeah, we want to make sure that everyone in our team, our care workers, our lifestyle staff, RNs, allied health, the doctors, and then other external supports that are involved, that we all are part of the team and working together and communicating. We also want to partner in care with the residents' representatives, with their families, and of course the resident themselves, so that everybody knows what's going on and everyone's aware of what someone's wishes and preferences might be. I think it's very important for us to check in with the family and make that, or the representatives, and make that something that happens regularly, and also provide space in handover or at other times for everyone from the team to communicate things that they may have noticed about the resident. So our care workers and our lifestyle staff, we really value what they bring to the team that's caring for that person. Teamwork is obviously very important. Our doctors are very important too, a very important part of that team. There's also the pharmacist,
Please continue.
The pharmacists and the residential medication management reviews, which happen, are really good at identifying medications that may not be helpful for that person anymore, and if deprescribing or rationalising their medications might, improve the person's quality of life, moving towards a palliative approach. So if we all work together, we can.
Mm-hmm. It takes a team.
Sorry, Liz, go on.
It takes a team. And, the importance of recognising when a person's entering that end of their end of life. I know, Dr. Arthur, if I can turn to you. Thanks so much, Louisa. What do you see as the most important considerations when managing the palliation of the end stages of dementia?
Yeah, I think, there are a number of things, but touching on the issues of working as a team and working and looking at all domains. So, one of the mantras of looking at a psychiatric way of looking at people is to consider all the different layers. So consider the biological, the medical layers, the psychological, the social, and the spiritual. So the spiritual is often the forgotten bit in many aspects of medical and healthcare, and that's certainly, if it's important for the person or the family, that's a really important part of it. But going back to the biological, I mean, they're the things that can be sometimes quite easily attended to and fixed, and can make a really big difference in terms of how the person is. So, as we just heard, the whole idea of deprescribing, for example, I mean, we know that medications are such a big cause of making people, especially people with dementia, much worse in terms of developing a delirium or a confusional type state. So those sorts of things. The other common things are people developing superimposed infections, which can lead to more confusion, and they're potentially quite easily managed and can make the palliation so much better in the later stages if that's what the person wants and that's what the family wants as well. And similarly, attending to things like constipation, which can also lead to very significant difficulties for the person. So, very simple biological things, checking on the comfort of the person, and then utilising what we know can work as well, which is not ideal in earlier stages of dementia, but utilising medications potentially which might help with controlling the symptoms of psychosis. If someone is experiencing horrible visual hallucinations or experiencing other things that might be able to be controlled with medications, but of course balancing that up with the potential side effects of those medications and what the harm that they can do, and then looking at all those other layers, like I said as well, the psychological and social and spiritual layers.
Thank you, Dr. Arthur. Can you suggest for our audience where they could expand their knowledge and skill sets around managing those end stages of dementia?
I think I can't suggest anything specifically off the top of my head, but looking at, there are a lot of resources with regard to the behavioural issues around dementia, and they certainly can be very important in terms of the the latter stages and the palliation of dementia. But essentially, if in the team is included someone who has a really good grasp of these sorts of things, typically would be a geriatrician. I mean, a geriatrician's bread and butter is dealing with these sorts of issues, but also psychiatrists, especially psychiatrists that have an interest in old age psychiatry. So what used to be called psychogeriatricians or old age psychiatrists, but also GPs have become incredibly good at dealing, not all GPs obviously, but the GPs with an interest, and the GPs that attend, especially the GPs that attend facilities, the aged care facilities, they can also be incredibly good resources with managing these issues, especially the more medical and biological issues.
Wonderful. Thanks, Dr. Arthur. Thank you so much. Well, shortly we'll ask our wonderful moderators, Vicky and Taylor, to identify one or two of your most popular questions. We have a large number, or a large audience joining us today, and there are many questions that have been popping through. But first, as promised, some exciting news regarding Dementia Australia's award-winning app, Ask Annie, that we've created. It's a new free course, a palliative approach to dementia care, which has been generously funded by the Frondetha Care Foundation. And the course in the app supports care workers to build confidence, things that we've talked about today, and capability in providing a quality palliative approach to dementia care. And like other Ask Annie courses, the learning is designed to appeal to various learning styles and features quizzes and branching scenarios and interactive questions to engage and enhance your learning. I'd like to turn to Louisa. If I can ask you from Frondetha, could you share with us how Frondetha staff have been involved in the project, and why do you think it's important for us to provide a culturally appropriate palliative care, as Dr. Arthur has mentioned?
Thanks, Liz. Yeah, it was really exciting. Is the connection all right? We were involved from the beginning in developing the modules and the app, identifying particular cultural needs or consideration be interesting or might be an educational need for our staff or for anyone else who is looking after or caring for someone with dementia, particularly from a Greek background. Then our care workers, some of our personal care workers, were involved in testing the app too, and then we've been using it since then. It's been really great. It was really good for our staff initially to reflect on what cultural considerations there are and how that might be different to in our setting compared to in other settings. There's some things that come up that are challenging for staff, especially staff who aren't from a Greek background, and so it's just really helpful to have the app to go to and as a learning tool. One thing that comes up sometimes is food, and part of Greek culture and many cultures is food is sharing food and giving people, helping people to eat beautiful food is an act of love and of care, and it can be very challenging and distressing for families when their person with dementia isn't interested in food or isn't able to eat anymore. And so there's some resources in the app or some education in the app about how we can respond to that when it comes up and support families to provide care in other ways and show their love in other ways. It's been really, really good for us to be a part of.
Wonderful. Thanks, Louisa. And excuse me, we will be popping up the QR code so you can quickly access the link to Ask Annie. Thanks so much, Louisa. Now I'd like to turn to our moderator, Vicky, for an audience question. Vicky, thank you.
Thank you, Liz. Okay, we've got a great one here. How would you approach palliative care for people living with younger onset dementia?
Thank you. And we may direct that question towards Louisa. Thank you.
Thank you, Liz. We don't get a lot of people here in residential aged care with younger onset dementia, but of course it does come up. I think we would be asked similar questions. We would try and get the person, the resident, involved as much as possible. Sometimes, as Dr. Arthur mentioned, the person with dementia who's received the diagnosis might not be able to grasp everything that dementia will entail, or all the decisions that have to be made, but that doesn't mean that they can't express some of their wishes and values. So we might look at that where before they move into care. Some of that might be around where they want to live, but when they come into care, it might be about where they want to stay and whether they want interventions and hospitalisation, and how aggressive they would like those to be. So some of the questions be around how they want each day, and what kind of things will bring them meaning as they live each day. So similar to how we would look at palliative care with our usual population of older people. I imagine that there's a lot of support for the family too of someone with a younger onset dementia, because that can be particularly challenging and distressing.
Thanks, Louisa. And Geeta, would you like to add to that? Thanks, Louisa.
Yep. Thanks, Liz. Yes, we do have a lot of clients with younger onset dementia, and getting that diagnosis at younger stages of life can be quite challenging, because they would still be working or would have young kids or some commitments that they need to get sorted or plan ahead to think about what is going to happen. And especially with younger onset, it does not only affect the person living with dementia, but also the whole family is affected. So just making sure that the family is being looked after well as well. And whatever we mentioned earlier, like looking at the holistic approach, including providing some support with counselling to the person who has got the diagnosis and the partner or kids as needed, and guiding them with peer support so that they can talk to other people living with dementia in similar situation has been quite helpful.
Wonderful. Thank you so much, Geeta. And Dr. Arthur, would you like to comment there?
Yeah, there are specific services that have been set up specifically for the younger onset group. So the one that I'm very aware of is the clinic that runs out of the Royal Melbourne Hospital. So that can be accessed and assist with, especially with working out the precise diagnoses and what the likely prognosis is going to be, and then what sort of services are going to be required, because the younger onset group does include a lot of people with fairly atypical type dementias compared to the older group that we see with the Alzheimer's and the vascular type dementias, which are much more common. So they may present quite differently, and one of the striking differences could be that the person might present with very significant personality changes, which of course we can see with the other dementias as well. So there can be really different challenges with some of that group in terms of how they manage themselves and how the family are able to manage when their loved one is really quite a different person to what they were before the disease began.
Thank you, Dr. Arthur. And I think we have time for one more question. Vicky? Thank you.
That's great. So I've got another one here. How can we be proactive in falls prevention for a person living with dementia at the end stage of their life, when mobility tends to decline quite suddenly and falls numbers increase rapidly?
Who would like to take that one?
Well, that's a huge concern. Sorry, I'll jump in. We see that a lot, and it's almost a warning sign for us. Someone who's has an increase in falls, it's a sign of a decline often. I think it's really important to look at, just as Dr. Arthur mentioned, health issues that might be able to be fixed relatively easily. A medication review is often really helpful to make sure that the person's medications are not causing or contributing to falls. A delirium, if the person has an infection or a delirium, can be making them more prone to falls. To making sure that their footwear is okay, that they've got things like protectors in place, chair sensors and bed sensors, so that we can be alerted, our care staff can be alerted to when they're getting up to move and come in to support them there, because obviously the person may not realise that they need assistance and know to ask for assistance. So I think like a good review of the person's health status can often identify some things that might be that we might be able to modify or fix. But then, yeah, supervision and trying to look at times that they're more likely to fall and provide more supervision in that time is really important too.
Great. I think we've got time. Thank you very much, Louisa. I think we've got time for one more. Thanks, Vicky.
Okay, what do I have here? At which stage of dementia should we start referring the client to the palliative service?
Dr. Arthur, I might throw that one to you.
Yeah, I think that's a difficult one. I think it depends on the palliative services and what they're happy to do, because I frequently hear that the palliative services are keen to have referrals sooner rather than later, and often it's more, the barrier is often more the service providers or families who are more reluctant for palliative care services to be involved, because it means that death is around the corner. But I know that palliative care health workers, they're more of the mindset that shouldn't be the case, and that they should be involved at very early stages in terms of planning and then assisting, and not right at the final stages. But again, I think it depends on what the resources are and what the individual palliative care services might be okay with. Just if I can make a point about the previous question as well, the other, I agree totally with what Louisa said about everything, but I think the other point is, in the earlier stages, to really make a point with people to focus really, really strongly on strength training and really good dietary intake to help with their overall health progression, so that falls can be less and less of a problem as people get progress with their dementia, or progress with with the aging process in general.
Great, thank you, Dr. Arthur. Okay, thank you so much. Geeta, did you have something to add there?
Just about the falls, I think everything we've said is quite helpful, like Dr. Arthur said. Look, we cannot prevent falls, so just looking at the environment and hazard, removing the hazard to prevent the injuries is going to be helpful at advanced stages of dementia, because their mobility has declined, like removing wheelchair out of their way, or any carpets that they can trip on, and things like that would be helpful. Also with the referring to palliative services, usually with us, what we found is palliative services will usually take the referral, but they might just say it's too early or late, because they usually come towards the final stages of life, which will be a couple of weeks to a month. But you could refer to Nightingale program if there are advanced stages of dementia, like if there has been decline in their bowels, urine, they're falling too much, eating has declined, and they're heading towards the end stage. You can always refer to Nightingale program, and then we can get in touch.
Right, thank you so much, Vicky. Thank you. And as I mentioned at the top of the hour, Vicky and Taylor, our moderators, have been working very hard in the background answering your questions online. They are also identifying the top 5 most popular questions, which will be published along with the webinar link, which will be coming to you in due course. Just some key takeaways from the hour today. Dementia is a progressive life-limiting illness, often overlooked as such. Palliative care applies by focusing on comfort, on dignity and quality of life through the dementia journey, not just at the end stages, by addressing the physical, emotional, and, as Dr. Arthur highlighted, the spiritual needs of the person and the family. In increasingly complex care environments, it's essential for us to assess the individual needs regularly, prioritising that symptom management and support staff with training in dementia-specific palliative approaches, of course. The person-centred care ensures the person's values and preferences guide decisions being made, even amid limited resources, and initiating those end-of-life discussions early in dementia. The dementia trajectory seemed to be a highlight there, which helps ensure choices align with the person's values. These conversations, of course, we know should be gentle, ongoing and inclusive of families. And, of course, important that staff, which our panel have discussed today, could be supported with training and empathetic person-centred communication to facilitate advanced care planning and uphold the dignity and autonomy of the individual throughout care. Well, that concludes our webinar today. And just before you sign off, a very warm thank you to Geeta Khadka from the Nightingale Project, from Fronditha Care, Louisa Storer, and thank you to Dr. Arthur Kakinius. I'd also like to thank our moderators and the incredible tech experts who produce our webinars, and to you, our audience. Thank you for joining us today. You're taking us a precious hour out of your day. Just a reminder, the responses, as I mentioned, will be published with the webinar link, and I believe we have, we'll be sending that out to you very shortly. And from myself and the team at Dementia Australia, we wish you a very good afternoon and look forward to seeing you in June for our next webinar, the topic of which will be released to you very soon. Wishing you all a wonderful afternoon and thank you.